Hello and welcome to the Dysphagia, Swallowing and Swallowing Disorders Review. I'm Dr. Maria Centeno and I'm here in behalf of the Therapy Ed group for students getting to be prepared for the praxis examination. I'm the Chair and Program Director for the A.T. Still University in Arizona for the Department of Speech Language Pathology program. Today, I have a good amount of objectives. We are going to be reviewing, identifying, understanding, and discussing topics related to swallowing that you probably studied really hard during your coursework, but now you need to organize all the information and put it together for your review. We're going to go over normal swallowing anatomy and physiology, identifying signs and symptoms of dysphagia, understanding neurological and structural medical causes, and discussing the assessment procedures and treatment approaches for managing dysphagia. Okay, if you have any question at any point, feel free to send it to the chat or send it later to our email so we can answer these questions during our office hours later in the week. Let's start with a little bit of terminology. Swallowing, as you know, is a very complex process that comes with sensory and motor components that will involve those phases or stages of the swallowing from the oral phase up to the esophageal phase of the swallowing. The swallowing process also allows that passage of solids and liquid or bolus from the oral cavity to the pharynx, to the esophagus, and finally to the stomach. When we think about how we define or difference feeding from swallowing, feeding refers more to the oral manipulation of the food prior to the initiation of the swallowing component of the reflex of swallowing, or what we call the trigger of the swallow. It involves from the use of the utensils to how you place the food in your oral cavity, sensory integration of the information that you're receiving from the food items you're gonna eat or you're preparing. So feeding encompasses more than swallowing. Is those initial anticipatory stages that we're gonna discuss later on. And that's how we define or differentiate swallowing versus feeding. And of course, one of the biggest topics for any SLP is that we're going to be the ones who are diagnosing, and this is within our role, our scope of practice, the disorder that we call dysphagia. Dysphagia, we're going to be the leaders in the industry in terms of the management of diagnosis, management, and education about dysphagia. And what is dysphagia? Is a difficulty or abnormality in moving food from the mouth to the stomach. Anything that goes wrong in those stages, we are in charge of finding the pathology or etiology that caused it, and which structures, physiology, or changes in the anatomy resulted in any of those problems. It's a symptom of an underlying condition. So I always say to my students, dysphagia doesn't come along. She's not a leader. She's always a follower. She comes, I say she to dysphagia, she comes as a cause, or I'm sorry, as a result of a previous cause or an etiology that is bringing that dysphagia. So there's an underlying condition or disease and may result from a variety of neurological, neuromotor, systemic, immunologic, developmental conditions, even trauma. So we're going to discuss more information about this in the further slides. Let's talk a little bit to what we all need to keep in mind that is really important, the swallowing anatomy. We think about the swallowing anatomy, we can divide it like in 4 big areas, and then within those big areas we have the structures, the systems, and physiology that makes them make that bolus to get safely to the final area. The first one is the upper oral digestive tract that comprise the oral cavity, pharynx, larynx, and esophagus. Head and neck structures, and when we think about head and neck structures, I'm talking about articulators and other structures like lips, teeth, tongue, hard palate, soft palate, hyoid, mandible, floor of mouth, facial pylors, epiglottis, and so on. And then we have, of course, really important, the pulmonary system that allows the airway protection and the support to protect the airway. Breathing coordination and swallowing are crucial, not only for adults in the apneic time where the swallowing is happening, but also for the babies when we're thinking about the suck, swallow, breathe process, when there's really very ingrained and well coordinated step by step from the neurological perspective from a human to protect the airway and to eat safely or to drink safely from the mother's breast. To the last area, that is the gastrointestinal tract, where we SLPs work up to the esophagus, but we need to be aware from the beginning of the esophagus in the US to the very end of the LES and the disorders that may be related that result in issues with peristalsis or structures that are impeding the bolus transit to the esophagus and then to the stomach in a well manner. That is like digestion when we get into the intestines. Going into those specific areas, the tongue in particular is one of the biggest roles or the actors in this process of swallowing, because the tongue is the one who manages the bolus from the reception of the bolus to the preparation of the bolus, mastication, and then to make that homogeneous bolus to then go into triggering the bolus to go into the oral phase to the pharyngeal phase. So tongue is so important that has a whole slide just for it. If you think about the tongue itself, besides the muscles, we can talk about areas: the tip, the blade, the center, or the dorsum. That is the one that you can see when you open your tongue and show outside in front of a mirror. And the pharyngeal areas, when we think about the base of tongue, valvular space, that is related to the areas that contain that tongue into space where it's housed during resting time or when you're managing the bolus. Moving into the pharynx. The pharynx is the other areas that are really, really important, and we found many issues with dysphagia clients. And when we think about pharynx and the whole pharyngeal area, we're going to start from oropharynx, nasopharynx, hypopharynx, laryngopharynx, and laryngeal complex. During the or the area what we call oropharynx is everything from the oral cavity up to the pharyngeal or posterior pharyngeal wall, and having those landmarks to be the tip of the velum and the base of tongue up to the tip of the vallecula. We think about the nasopharynx. Nasopharynx is from the enter of the nose, from the turbinates, passing to the choana, go back to the posterior pharyngeal wall where the soft palates ends. Then we have the hypopharynx, when we have the PPW and the lateral pharyngeal walls doing all the contraction to help that bolus to go with the pressure that is needed to move to the next stage. The laryngopharynx is where the vallecula, piriform sinuses, and laryngeal adductus is. So it's the area of, sometimes I call the danger areas. We're really close to the glottis and the vocal folds. So all those areas are important to keep in mind and to know where one ends and the other one started and how they overlap together for the safe travel of the bolus. And we have the laryngeal complex, where is when we think about the kind of like the voice box, but not the voice box. We're talking more about swallowing, so we're going to call laryngeal complex from the hyoid, epiglottis, cricoid, and arytenoids. All those cartilages that will be helping protect and guide the bolus to the correct area, that is the esophagus. Then we have the esophagus, and we're going to be looking a lot in some of the disorders that are related to not being as fluid as it should be, the transit of the bolus from the pharyngeal phase to the esophageal phase. And that sometimes is because the cricopharyngeal muscles and the laryngopharyngeal area or hypopharyngeal area gets with trouble. We get trouble maybe with the dilation of the muscle, maybe because it's too relaxed due to the reflux, or maybe because there's some changes in anatomy due to a diverticulum or a pouch, or the peristalsis make the stasis of the bolus in the piriform sinus, for example. So depending on where and what is happening, we're going to be paying attention how that esophageal phase and the esophagus may or not be interfering for the bolus to get to the final destination, that it will be the stomach. Now going into cranial nerves, and again, what we're doing here is a very summarize of everything that you should be doing. So this is just to give you an idea what you need to improve or add more information, or maybe clarify or come with questions to us, okay? But it's really important that you remember those famous 12 cranial nerves. So those famous cranial nerves are still here now for swallowing. And when we think about or talk about like cranial nerves innervation for swallowing, we get into more specific ones. I can kind of like relate each of those 12, but going more into specific swallowing disorder, the ones who are like the big actors here, we could start with number 5, trigeminal. The three nerves, the three branches, ophthalmic, maxillary, and mandibular, has some kind of innervation related to sensory or motor. Trigeminal nerve has some aspect that helps for clients or people who are managing the bolus. The anterior 2/3 of the tongue, the sensation of the teeth, gums, and oral mucosa, and the salivary flow from the parotids, submandibulars, and sublingual. When you think about the production of saliva that comes from those glands, it's a lot, and that glands needs to be really aware. Their sensory threshold needs to be able to identify how much saliva is needed or is missing. So sensory integration of this cranial nerve in terms of managing all the stimuli that is receiving is in charge of the trigeminal 5. After that, we can talk about the motor component. The motor component of the trigeminal nerve is related on how to open and close the mouth, how to move the mandible, and do the mastication. And if we think about that, mastication involves not only moving the tongue or managing the valves, it's just that small gradient of the jaw to be exactly for the size or the pace of the bolus that are receiving. So that opening and closing may be affected and resulted in trismus, or can be maybe having some restriction or some lesion that won't allow the client to manage. And trigeminal 5 is in charge of activating those muscles related to opening and closing the mandible, and innervation of the floor of the mouth muscles, elevation of the larynx and the hyoid, and that eolaryngeal excursion. There's a couple of muscles there that are working. If we think about next nerve, facial, number 7, also is sensory and motor. And you think about sensory and motor, we're going to be talking about muscles from temporal, zygomatic, buccal, mandibular, cervical area. And in this case, the sensory component is related to the sensory taste buds in the anterior 2/3 of the tongue, and the salivation of the glands of salivation, except the parotid. So in this case, we're going to be talking about sublingual and submandibular. In terms of the motor component, we're talking about the lips, the bilabial seal of the lips or clarisoris, facial muscles, floor of the mouth muscle, and cheeks to keep that bolus in place, elevation of the hyoid and the larynx to protect the airway. So we already have trigeminal 5, facial 7, and then we have glossopharyngeal number 9. And also is a sensory and motor nerve. And sensory is in charge of the taste buds of the posterior third of the tongue, sensation of the facial pillars of the mouth and soft palate, salivation of the parotid gland also is helping with that, and sensation to the pharynx and larynx. And when you think how much salivation we need, we produce around 1.5 liters of saliva every single day. Therefore, all these 3 glands are working really hard to keep your gums and your mouth ready for receiving and balancing those bolus that are being received. In terms of the motor component, also is working with bilopharyngeal closure, control of the upper pharyngeal constrictors. Remember, we have upper pharyngeal constrictor, middle pharyngeal constrictor, and inferior pharyngeal constrictor. So glossopharyngeal nerve number 9 is working more with the upper pharyngeal constrictors. Now we move into the vagus. Vagus number 10, that we know that is more very famous, known for voice and phonation, but in terms of swallowing also is very important. It's a sensory and a motor innervation cranial nerve. And if you think about the sensory phase that is helping, or which phase is helping, is the pharyngeal esophageal phases. Pharynx, larynx, trachea, valvular area, lungs, stomach, and abdomen. All of those sensory thresholds are in charge of cranial nerve 10. Cranial nerve 10 in terms of motor activation will help us with the base of tongue, with muscles related to pharynx, larynx like diaphragm, and lungs that are also used for phonation, respiration, and airway protection, and pharyngeal contraction, and of course the peristalsis of the esophagus. So when you think about cranial nerve 10, it's doing a lot in terms of motor and sensory. Then we move into spinal accessory number 11. This is completely motor. It's a nerve that is in charge of the soft palate, the uvula, the bilopharyngeal closure, the upper pharynx, and the stability of your shoulders and neck, and rotation of the head for managing the bolus when someone is eating. So that's really important. Then we get to our I think is one of my favorite, hypoglossal 12. What is my favorite? Because it's all about tongue, and it's all about what that big actor I mentioned before, the muscles of intrinsic muscles of the tongues to help that bolus to be received and managed during the oral and oral prep stages. So number 12 is the hypoglossal, in charge of all the muscles of mastication of the tongue, and innervation of the pharynx. Some of that eolaryngeal excursion, elevation, and airway protection also is innervated by muscles related to hypoglossal nerve. And with that, we finish with cranial nerves that are related to swallowing, or muscles related to swallowing. I'm just giving that a summary, but it's for you to go over your notes, to go over some of those pictures, figures, or tables to get and organize your cranial nerves innervation, sensory versus motor, and how it looks in terms of which nerves are innervating which muscles. We have a great amount of tables related to muscles in our textbook, or a review guide, and you can use that as a reference, but there's also many other books that probably you use for your dysphagia class or other anatomy class that you can use as reference to go back and compare and contrast. Okay, now let's move into cortical and subcortical, and what we need to talk about is cortical and subcortical, because there's some areas at cortical level that also are impacting or managing, in charge of the swallowing process. So we have the swallowing center, more subcortical in this case, is what we call the central powder generator. Remember that. Medulla and pons in the brainstem area are working really hard with swallowing center coordination. The ephrem components of our innervation, the motor part, is controlled by the nucleus ambiguous, and then the afferent or sensory component of the information that we're receiving is modulated by nucleus tractus solitarius. That's in a big simple summary, but there's a little bit more of that number of coordination and interactions between corticals and subcortical structures that, if you're not fresh, go back, just try to draw it, try to practice, say it out loud, and you get to make more sense of all of this when you put it together. We have seen in MRIs and PET scan that all these areas that are related to cortical innervation or activation are the ones that are helping also the swallowing. So sensory motor cortex, insula, putamen, globus pallidus, thalamus. Of course, thalamus is like the relay center. Everything goes through there and gets dispatched to other areas. Supplemental motor areas, subcortical areas, cerebellum, basal ganglia. So keep in mind that it's not an isolated area, the cranial nerve innervation or the brainstem, but there's some other cortical and subcortical areas that you need to be more familiar. Okay, so I think we can start moving a little bit out of the anatomy. Just remind, you need to go to your anatomy. You need to go to those muscles. Get very familiar with muscles and nerve innervation, and you'll be fine. And the idea behind this is not because you're gonna be like a nerd in anatomy, is that it's gonna help you later for diagnosis and for treatment plan or plan of care. Okay, so we know that many literature or books out there are going to mention oral phase, pharyngeal phase, and esophageal phase, and the ones that I'm most used to have oral preparatory phase, oral, pharyngeal, and esophageal phase. But there's also some literature now also mentioning what we call anticipatory phase. That is that phase when the person is start to looking at the meal or the boluses when there is being prepared, the type of boluses are presenting, how their sensory response to the bolus is, and how the saliva is start producing, and your cortical areas are receiving that visual representation, that smells in terms of sensory, that will help you prepare your oral milk, your oral cavity in terms of saliva, opening when receiving the first bite or the spoonful of ice cream or anything you're eating. So that anticipatory phase is being described at that moment where all the sensory anticipatory activities are happening in preparation to receiving the bolus. When we start putting that bolus close to the mouth and we start opening our mouth to receive it, is that oral prep phase where we receive the bolus, start formatting the bolus by biting, by chewing, mastication is happening, really nice labial seal, like lip closure, and then we're ready to go and prepare our bolus for the next phase. So all that movement, all that jaw back up, going in rotation or rotatory movement, all those muscles are getting ready or producing enough saliva para to go to the next step, okay, to go to the oral phase. One of the things that we're going to be looking at is like how the oral phase is or not related to the preparatory phase, because some people like always are saying, oh, I think that is when you put the tongue down, when you put the top up. It's really hard to separate one from the other, but we do know that once the bolus is completely like ready, with a head and a tail, we're just preparing to receive the next one, and the trigger of the transit of the bolus start is that initiation of the pharyngeal one. So that's when the oral is almost ending and pharyngeal is starting. So all the steps are starting when you put your tongue against your palate in the alveolar ridge, and then the wave of the tongue goes against the palate to push the bolus back, and the tongue goes down and the soft palate goes up, and the laryngeal excursion is starting, kind of like gonna start soon, and the airway still is open but maybe start closing, and all of that is a very nice synchrony, and that's what is so what we call like or overlapping of the phases. So once the tongue propulsion happen and we going into the next trigger of the bolus going down, is what we call pharyngeal phase. And that trigger, when the airway is closed, that apnea is happening, no air comes in or out, glottic area is sealed, inversion of the epiglottis is happening, your laryngeal excursion is completely up and ready, then that bolus that is going for sure now from volitional to completely not under control is helping the UES to open and relax to help the bolus go to the final phase, which is completely involuntary and there's no way back. The esophageal phase, when the peristalsis can start and be like as long as maybe 8 seconds to 10 seconds, depending on the viscosity and the size of the bolus, and that will be really synchronic. But the other phases maybe usually can take up around a second or less than a second between one and the other. So this is what we're talking about phases, because it's important for you to understand that every single one of those phases later we're going to be describing in our written reports when we're working with our clients. Okay, now that we think about the phases and how we swallow and how this is so interconnected, what happens when we're swallowing? What changes may happen that will stop one of those phases to happen correctly or to interrupt those swallowing stages correctly? So one of the things that we know that are normal and that is very appropriate is what we know aging. Aging is happening to you every single day, and it's not any different for our geriatric population or aging population. With those changes results with increasing the duration of the swallow, delaying that movement and fluidity and pace of the protection of the airway, and elevation of the laryngeal excursion, and the opening of the US takes longer. There's less pressure because maybe sarcopenia is happening. The pressure of the tongue also is maybe reduced because of the sarcopenia, and the penetration accidents or aspiration may be a little bit more frequent than in a younger folks, and the cough or the protection of the airway maybe is even diminished or reduced. So that's happening because of aging. It's very normal to see sarcopenia, adults, aging geriatric population choosing more soft and easy to chew boluses. There's a different or very severe GERD or LPR arthritis that won't allow those cartilages to move fluently. We will see that the oral mucosa is changing, is this thinner and less elastic. The color is changing. The xerostomia may be happening, really thick saliva or very dry mouth, and of course senses are diminished or decreased due to aging. So smell and taste will be reduced. That's something that we call presbyphagia in many places, like presbyacusia for hearing loss related to aging. So presbyphagia in relation to swallowing. Then we're going to, okay, now you're already talking to me about changes in swallowing in aging. So these changes in aging are not related to a difficulty called dysphagia. It's more because of aging. That's what I call presbyphagia. But let's talk about the definition or term dysphagia. Phagia comes from Greek for phagum or phagos, meaning to eat, and this meaning to be disorder. So if we have a client who has dysphagia, has difficulty to moving food from the mouth to the stomach. There's what we call the red flags or signs and symptoms that we always need to look for in our clients. Like they talk about odynophagia, they talk about feeling things stuck, or globus sensation, or choking, or they're scared to eat because they feel that they're gonna pass. So all of those signs and symptoms, like drooling, changing color, some teary eyes, goes kind of similar even in babies versus geriatric, but are very common signs and symptoms that you should be aware and that you should be familiar. So there's a table in our guide that you can make reference with the signs and symptoms, one of the most common ones, so you can be more familiar with signs and symptoms related to dysphagia for you to make referrals or to work with your clients. Let's talk a little bit about how or which are the most common etiologies that results in dysphagia. As I mentioned before, dysphagia is not a leader, it's a follower. So the leaders are these etiologies we're gonna kind of summarize for now in a minute. Some of the most common etiologies are related to neurological changes, including strokes, traumatic brain injuries, Parkinson's disease, ALS, dementia, myasthenia gravis, Huntington's disease, traumatic brain injury, as I mentioned before. So anything neurological can impact, of course, our swallowing and therefore result in dysphagia. Structural changes like head and neck cancer, osteophytes in their cervical area that comes with aging most of the time, neoplasms, medical conditions like GERD, gastroesophageal reflux, and intubation. It may affect for voice and vocal cords, but of course also may impair the glottis to closure well and to protect the airway, or any other iatrogenic condition. I was doing a research recently with a student of mine about thyroidectomy, people with head and neck cancer of the thyroid, and how that population or demographic may be resulting in some dysphagia or voice problems due to cranial nerve 10 being maybe affected or caught or a lesion in the area. So there's anything that may be a cause for a medical treatment that results in dysphagia is what we call iatrogenic. And then we have developmental babies in NICU with multiple disorders. That's a big homework for you. I know that you probably already have a list of congenital and syndromes that comes like craniofacial anomalies like cleft palates or Vater or Chiari malformation. There's many tracheoesophageal fistulas in babies. So pediatric populations may have issues. Also behavioral issues secondary to sensory integration that may reduce what we call, or sometimes is related to feeding disorders, cerebral palsy, muscular dystrophy, Down syndrome children are children that may result in having dysphagia or feeding disorders. Now, going into those etiologies, if you think about strokes or CVAs, we do know that, or you may remember, that brainstem strokes are kind of like, by default, the ones who are going to be for sure having dysphagia. I will say, like, if I have a multiple choice question that says brainstem stroke versus like left middle cerebral artery stroke, which of the two will be mostly an aphasia client? Of course it will be the left MCA, but if it's of the two which will be most for sure have dysphagia, then will be the brainstem one. It depends. This is a very broad example, but it could be the case. So bilateral strokes have poor prognosis because we have less area that is still preserved. Pontine, because of the area where the pons is, will result in absent swallow response or delayed response due to the hypertonicity. In the medulla area, nucleus tractus solitarius, nucleus ambiguus is there, so the response from the pharyngeal phase and pharyngeal muscles related will be affected. The UES relaxation will be, or the UES opening will be delayed. Therefore, the trigger of the swallow also may be delayed. There's stroke, Wallenberg's syndrome, that may result in medullary infarct as a result of medullary infarct. That also, besides having the swallowing problem, will have dysarthria and ptosis. That is when the eyelid is a little bit, heavy or closed for those clients. Numbness, vertigo. Some of the things that we have looked in terms of strokes, depending where the area of the brain was affected, you should be thinking about the language, the cognitive, or the motor, and sensory components. And if we think about motor and sensory related to swallowing, you need to know your cranial nerves and the areas in the brainstem, like pons medulla, that will be affected. If we have a stroke in the subcortical areas, maybe a milder symptoms, and if it's cortical, right is more pharyngeal phase issues than left side, where it will be more oral phase issues. So it's really important for you to understand the different areas of the stroke where it can be affected, the stroke, and then you will have better way to make your hypothesis when you're looking at your clients. So that's one big, because it's one of our biggest percentage of clients that we receive as adults with dysphagia, stroke clients, but also Parkinson's disease is one of our clients. We know that Parkinson's, we start working with them from the earliest stages, with voice and Lizzie remote voice treatment, or speak out, to swallowing and cognition in later stages. And Parkinson, due to their movement disorder issues, are hyperkinesias, we may see different situations. For example, due to the dopamine depletion in substantia nigra, we'll see that their ability to protect the airway and to clear the airway from residues is harder. Some of the medication that is used for prescription is levodopa and Simenet for the dopamine reduction. But we'll see a lot in our clients that tremor and rigidity to also be reflected in the hypopharynx area. When you do a face of the Parkinson clients, kind of very similar to what you're seeing in terms of dyskinesias outside in their motor, like extremities, is what you're seeing also in the hypopharynx and the protection of the airway. That resting tremor is present, and therefore the strength for them to cough and protect the airway is also reduced. So that lingual rocking of their tongue, that is, that tremor is happening there, and the pharyngeal dysmotility, because that control, the motor control, is affected, and then pulling in the pharyngeal area, resulting in that dysphagia that we need to help and work. These clients will, in most of the cases, will deteriorate to the point that there's going to be resulting in penetration and aspiration, and even silent aspiration, because a lot of residue is in the hypopharynx in these clients at resting, in the vallecular area, in this piriform sinus, and it goes into the airway. One of the treatments very common that we're seeing more and more research and from Dr. Chosh and colleagues, Triana Steels and others, is the use of the EMST. Before, in the past, we were using a lot more breather, and now we're using also EMST and RMST in combination with LSVT or speak out as common treatment for oropharyngeal symptoms. And that is something that we are using in combination with our swallowing approaches or our management of swallowing issues. We use some of those components that we use for voice related to Parkinson also in combination with what we do for the swallowing or dysphagia problems that they're presenting. We have the progressive supranuclear palsy. Any cerebral palsy or variation of that may result in issues with brainstem, like basal ganglia, cognitive loss, and dysphagia that may result in coughing, choking while eating, and that will impact their amount of nutrients and diet that we can present, and the ITSE levels that we're going to be recommending for these clients. ALS, as you know, depending on their type of ALS, if it's more like bulbar or what diagnosis they have, it's a progressive degeneration of the upper motor neuron and lower motor neurons. It may result in dysarthria, motor dysfunctions. They are preserved in terms of cognitive skills, so they are very aware of everything that is changing. Respiratory function is affected, therefore protection of the airway, coughing and helping to protect the airways is harder for them, and they will require use of PEG as an alternative feeding method. PEG tube is something that me as a specialist in swallowing don't love to have our clients, but in cases like ALS, sometimes it's imminent, the need of a PEG. There's no cure, and a lot of counseling is needed for this population. Myasthenia gravis, you probably have seen, is very common in women also. Lower motor neural disorders. Instead of dopamine in Parkinson, here for myasthenia gravis is acetylcholine neurotransmitter that is the deficit. There's weakness, and the weakness exacerbate with work. We should never give them oral motor exercise, for example, because that will fatigue or extremely weaken their structures to protect the airway or to do other activities, motor activities. Some of the assessment uses the tensilon test for them. Treatment includes medical treatment, removal of the thymus gland, thymodectomy, that's a really hard word to produce, and includes in our part a lot of like modifications from the size of the meals, and increase the frequency of the meals in the morning, and maybe the stronger meals in the morning versus the end of the day, because they get to be more weak at the end of the day, and modification of textures to make it easier for them to manage. Clients with multiple sclerosis is another etiology that is very, very known. It's the immune system, the myelination of the nerves. Multibulbar tracts the brainstems are affected. Delays in trigger of the swallow. Medical treatment, high dose of corticosteroids is needed, and will help this population that, as you know, have different flares depending on how the condition evolves. Huntington disease is an autosomal dominant neurodegenerative disorder that can be detected with a blood test, and is something that you would get from someone in your family. Sometimes there's a 50% chance. Progressive psychiatric changes and dementia, choreatric movements, and respiratory failure and difficulty to protect that airway. Oropharyngeal dysphagia, they will need a PEG tube, and we will focus more in the posture, in facilitate the intake, and to control as much as we can their impulsivity and pace, because they have a really fast pace while eating, and that may result in overly filling their oral cavity, and is a choking hazard for them. Post-polio syndrome is a viral degeneration of the lower motor neurons and brainstem, degeneration of the motor neurons, end plates of the nerves, of the muscles and the innervation areas after polio, several years after, and they develop those dysphagia symptoms that are found to be in all phases. Postural diet changes are things that we do a lot with this population and help them. Guillain-Barré syndrome, as you know, is an autoimmune disorder that affects the peripheral nervous system, resulting in the myelinization of the cranial nerve. Weakness, sensory loss in the oral cavity, pharynx, and larynx, therefore the possibility of aspiration is higher. There's a medical treatment that includes plasmapheresis and intravenous immunoglobulin. These clients, sometimes they never knew they have this syndrome until it's just it was dormant, and it just started when an area of stress or something happened in their health. Other disorders that we see, and there's many more. We can be here forever. I'm just giving the most common ones: is dystonias, dermatomyositis, TBI, like closed-head injuries versus penetrating head injuries. Depending on the type of injury and where the injury was, may result in issues with posture, management of the bolus, cranial nerve innervation, and so on. Dementia. I know we have a lot of dementia, and that cognitive impairment and that dysphagia appear in that volitional eating and transporting the food into the mouth. There's a lot of need in terms of like spatial, like organization of the environment and recognition of what food items, because they present food agnosia, and they have feeding apraxia and difficulty to manage the bolus. Then we have geriatric patients, and when we think about geriatric patients, we have to always comes with dementia, maybe sometimes come with Parkinson, so all of that, but we can always keep in mind that bolus flows is one of our areas that we're going to be looking, posture and diet modification. Okay, just to be keeping in mind that sarcopenia comes and that will result in fatigue, and that's what we have to keep. Boluses are easier to manage or softer, and considering maybe working on strengthening their structures, like what we do with IOP, that right now we have also the tongometer that will help strengthen the lingual muscles or the tongue muscles to manage that bolus more effective. Then within the central nervous system, is important now that we're talking about IOP and other approaches to think about how the current central nervous system may alter or change itself in terms of like recruiting areas that were not active for swallowing or for motor or sensory, but after an injury now it goes is what we call plasticity. So through sensory stimulation and practice, skill acquisition or repetition results in ability to replicate new things that before were not the common skills that were associated with those areas. So that's what we all believe. SLPs, I think this is, I always say a joke with my students, if you're not a believer, you need to leave, because neuroplasticity is what help us changing people's tasks or helping them learning new tasks. And that's when it comes the principles of neuroplasticity. If you don't use it, you're losing. If you don't practice eating, you won't eat. That's why we need to keep our clients managing their own saliva, because if they don't use their oral make besides having a peg or an NG tube, then they will lose it. They need to keep active their structures and use it to improve it. So like IOP, just use it and improve it, like with the EMST for the muscles of the lungs. Specificity, what targeting we're doing to help that repetition matters, intensity matters. It's like when you go into the gym, okay? Time matters as soon as we can, as much as can be related to what you're doing. Age, we know, matters, okay? It doesn't mean that it's not impossible for aging people, but it's harder than for younger. Transference, to move it from another place, and inference. When I say transference, that you can take it from one area and generalize that to another. Head and neck cancer and dysphagia is a big population. We see it in the oropharynx, larynx, esophagus, and may impact the swallowing. The surgical, radiation, chemotherapy, all of that may result in structures with fibrosis and necrosis of tissues that will allow those bolus and muscles contraction to be as fluid as before. Poor prognosis, depending on how and when it's detected, they will lose their teeth, rat patches, bleeding, dryness, candida, pain, odynophagia, feeling that things get stuck, and that's why they have different stages where we should be involved in their treatment from the very beginning when it's detected to the very end when it's managed. The population that is a risk factor for head and neck cancer is smokers, alcohol consumer, people who are exposed to sun, HPV, reflux or severe reflux or laryngopharyngeal reflux. Really important for you guys, get ready to know the TMN. TMN is the sizes. T is 1 smallest, 4 is largest, N is related to the lymph nodes, no involvement or involvement, and M is metastasis already, from 1 no metastasis to 1 0, that is metastasis. Okay, Head and neck cancer management, we're going to be checking on what they do in medical, so we can intervene as soon as we can in every step of the way. But they start detecting it with CT scan, bone scan, MRIs, the reconstructions from tissue flaps, grafts, removal of structures, dental prosthesis. We do our dysphagia evaluation prior to surgery and after the healing of the acute stage, and we work a lot with interprofessional, interdisciplinary approach with all the team members. Some of the things that are important is depending where the cancer or the tumor was, we will remove parts that will impact or will be structures that were important for swallowing, like tongue tumors. Less than 50% of the tongue is removed is a good prognosis, but more than 50% of the tongue is removed, they for sure will need therapy, reconstructions, and more therapy. A total glossectomy for sure, base of tongue motion will be almost reduced or minimum. Difficulty with bolus propulsion, reduced laryngeal excursion, suturing, depending where is suture, may result in problems for the management of the bolus and the transfer from the oral prep to the oral to the pharyngeal stage. So there's going to be very, very specific individual aspect of those surgeries that may result in you managing their symptoms in a different way. Depending on where the tumors is, if it's in the hypopharyngeal area, laryngeal areas, you may have different consequences and different approaches. It's not the same if it's supraglottic versus if it's subglottic or in the glottic area. Okay, you may or may not have a tracheostomy tube. You may or not have a possibility to manage swallowing, and they maybe it will be a PEG for these clients from the very beginning. So, or it could be a radical total laryngectomy or partial laryngectomy or hemilaryngectomy. So depending on the type of cancer, the type of intervention, and how fast it is, the preservation of the structures gets to be more or less aggressive. We can work as a clinicians with TEP clients, tracheoesophageal punctures, and voice prosthesis with Passimure if they have a tracheostomy tube, and or devices like Therabite for trismus after the therapy. But all of those in relation to swallowing, of course, because there are going to be issues with management of the bolus, serostomy is present, and so on. Penetration aspiration, what I put it here because now we're moving a little bit out of the head and neck cancer and other etiologies into how we manage this. Penetration aspiration is like the most common symptoms that we use for diagnose when we do instrumentation and when we are suspecting our clients to be having big problems with dysphagia that results in aspiration pneumonia that can lead to death. And it's important for you to know this 8 points aspiration penetration scale from Dr. Rosenbeck, and that will give you the severity of the aspiration or penetration episodes, from 1 being normal, everything is good, to 8 being a silent aspiration where there's no effort to clear the airway. Esophageal issues, as I mentioned before, from Senker, diverticulus, achalasia, structures of the esophageal area, rings, scleroderma, tumors, pill-induced esophagitis. There's many things that may happen with esophageal. Just remember that amount of muscles that are in charge of that peristalsis, the ones who are like the soft ones, or the ones who are more striated muscles or smooth and striated muscles are working really hard, but the coordination of those movements and the strength can be at risk due to these conditions. And we all are working more and more than before in esophageal assessment and treatment. Okay, what we do with our clients, we're going to be checking on how neurologically we can help them or has been helped by the neurology. Same with the control of the saliva or production of the saliva, because after treatment saliva can be serostomia or could be sialorrhea, and the coordination of those muscles movement, the sensory awareness of the clients, and the level of alertness. So think about how you will write that in a report, and then that will help you go back into muscles, and from muscles function, and from function what is wrong with it that resulted in poor peristalsis of the bolus or poor transit of the bolus. But never forgetting that medication may have a huge impact in swallowing in the bolus because of xerostomia or hypersalivation, that is sialorrhea. Some of the clinical presentations that we know, and I mentioned the signs and symptoms from the table 17.2, is also how you're going to write that in the report. This is just like an example of when you think about a client and you're looking, okay, there's drooling, there's pocketing. Anyone can do that. I say my students, someone who doesn't know anything about dysphagia sees saliva coming out, oh, you're drooling. So that's good for you to be able to say it, but I need you to understand why they are drooling. They're drooling because their lip closure is not good, orbicularis oris is not working, then which cranial nerve is innervating that. So that will help me and say that neurological issues are happening that are impeding that lip closure to be as sealed and strength as I want, or to retract as I want those lips to be able to, maintain the bolus inside. So that's what you later going to be writing in your report. So there's going to be issues with motor coordination of the so-and-so, resulting in drooling. Okay, but always remember to use that, because that will help you have a good description of what's going on in terms of the neurophysiology of your clients, or the symptoms are presented related to neurophysiology. Same with every other area. Pharyngeal, you're going to be looking at coughing, wet voice, throat clearing. So when you hear that there's coughing, usually it's because something gets into the airway or close to the airway in the vocal folds area or ventricular area. PPW will be residues maybe in the vallecular, in the epiglottis, piriform sinuses. So that cough, that wet voice, that throat clearing is because there's some of that residue. Maybe you're just listening to the cough or listening to the wet quality. You're not seeing anything just yet because you haven't done instrumentation, but you start making assumptions that there's residue in one of these areas, or maybe in all of these areas, depending on how severe the case is and what you're doing as your intake of your client's history and signs and symptoms. Okay, so we know that silent observation is dangerous because nothing is being heard or produced from them that may guide you in making an assumption, oh, this client is having an aspiration, because you don't even see a sign. There's no sign and symptoms, it's just eating and nothing is happening. So that's a very dangerous situation, and that means that there's decrease in sensation, sensory thresholds are diminished, and the response to an invasion in the airway also is diminished, so the reflex to protect the airway is not there. And how we get that, and that's why I'm mentioning all of this, because it's when you're doing your assessment, your hypotheses are happening when you're doing cranial nerve examination, when you're doing your history taking of your clients, and that's happening when you're doing your CSE. That's the first part of an assessment in dysphagia. The CSE is a clinical swallow evaluation, when you start with the interview, questionnaire, quality of life, maybe screeners, chart review, oral motor examination, cranial nerve examination, fitting assessment when you start presenting the boluses or the trials, and making that decision which of the instrumental swallowing studies are you going to be doing. Are you going to be doing a FEES later, or an MBS, or video fluoroscopy? There's many protocols out there, from Dr. Leader's Yale Swallow Protocol, MASA. You can use the FOIS. That FOIS, I love to mention the students, is really easy to use and add to your report, because it's a way to describe how this current stage of their swallowing of your client. So give you more information besides the PAS for severity. So you start doing your CSE and taking all this data and making more objective, even though you haven't yet done your instrumentation. You can incorporate the norms from ASHA to describe how the functioning of the swallow is, and also any other reported outcomes measure that we have, like the E10, that is a good screener from the Nestle and is in multiple languages, the SWALCO for quality of life, Dysphagia handicap index, MD Anderson inventory. Depending where you're working, what you're setting a scenario, just get to know your tools and what these tools are for, what information they're giving you for your report and for your final diagnosis. Once you get out of your CSE, you're ready to make an instrumentation, and the most common one, the gold standard one, is BFSS or MBS. That is the one that we do in the radiology suite with the radiologist. Is the one that we are able to see all the phases of the swallow with a lateral view, and we see this radiology image from the bolus getting into the mouth to the esophagus, so we can see all the phases. Many of you probably have gone through the MBS IMP, or you have heard about the MBS IMP, where we are looking at every single phase of the swallow and how the bolus gets into that final phase of this esophageal phase, and you can describe what happened before, during, and after in every phase of the swallowing. That's the VFS. That's our gold standard. We can also have an anterior AP view, anterior posterior view, where you can see how the bolus divides into and how it gets reunited again, going into the esophagus, and you can even see some of those specific situations that are happening in terms of anatomy that you can maybe refer for consultation or for diagnosis for other specialists. So the MBS has been the gold standard, but guess what? FEES is getting really close, and some people are calling now FEES also a gold standard. And there's a lot of strengths in the FEES because we can see the 3D view. We can be with our clients for longer periods without being under radiology or x-rays, and the client fatigue can be measured if we want to, versus in the MBS that you cannot be there for a longer period. So there's a lot of many good strengths about FEES, and you can see the amount of residue and where the residue is or secretions, versus with the MBS is harder to get that information. The problem with the FEES is that you cannot see all phases like I mentioned in the MBS with the radiology suite. Here you only see very specific areas. You cannot see the oral phase, and you cannot see exactly when the bolus get into the esophagus because of the whiteout. So those are there. This is just a few, but there are more in terms of how easy or hard for some patients is to get into the MBS suite. If, for example, it's a bariatric patient because overweight, versus a FEES that you can even take it inside the NICU, or you can take it to the patient's house. So for the MBS, you have to bring them to the radiology suite. There's the barium used in the MBS versus the FEES that we lose the whiteout stage or the oral phase. So you can compare and contrast and create a really nice table, and that will help you get more fluid in what are the limitations and strengths of both of those. But we also have more. This is not the only ones. We have the electromyography, we have ultrasound, high resolution manometry for esophagus is very common now. We're getting more and more clinicians doing research and doing use of high resolution manometry for swallowing. It's also scintigraphy, fMRI, not that common in our field for clinicians in hospitals, but it's still out there as a good tool. And then when you get your diagnosis, you can see with your maneuvers how they work or not with your client when you're doing instrumentation. Then you can start moving into which treatment approaches I'm going to select for them. Compensatory strategies, rehabilitative exercise, diet modification, counseling and education, or maybe all. So you make the decision which will be the best for your clients and what it will work for their swallowing to be safer. We kind of divide them in what are direct treatment versus indirect treatment. The direct treatment are the purpose to modify the swallow by modifying the food or feeding methods, like with postures, the size of the bolus, textures, flavors, stimulation strategies. We use a lot of biofeedback. We can even use EMG and the ultrasound for direct treatment, so they can see how everything is happening. So we can use some of our swallowing strategies, like supraglottic, postural changes like chin down, chin tuck, head turn, head tilt, as needed. Always remember, when you're doing the assessment, you will use them. Compensatory strategies in direct treatment is more of immediate safety. Remember, always about swallowing is about safety and efficiency. Okay, we want to be sure that everything goes where it needs to go, and it needs to go fast and efficient. Okay, so we don't want anything to go into the airway. That's the safety, and we want to make it really good so we don't have residues or secretions in the areas of danger. So keep in mind that we're thinking about immediate safety, those postures, those diet modifications, maybe selecting if we're going to be using or not thickeners. There's a lot of controversy here recently in the past years about the use of thickeners, and especially in pediatrics. But when is a good discussion with your supervisors and your clinicians and the providers of like primary care physicians. These compensatory strategies, they don't change the swallow physiology, but they help with the safetiness of getting that bolus to where we want to send that bolus. In terms of the indirect treatment is when we start working more in rehabilitation, in not just to get the food to a safe place, but to do exercise, to do more treatment. Okay, and you can do both with your clients. It's just that you need to be understanding that ones are for indirect and others are for direct. In this case, it's more for oral exercise, for example, that will help in sucking better or chewing better, or be a better lip closure or lingual movement with the IOP. When you're doing an IOP, you don't present a bolus. Okay, so but when you're doing a supraglottic, you are presenting a bolus. So there's differences there that you need to keep in mind when we're thinking about indirect versus direct treatment. So these rehabilitative approaches, we're looking at Mendelssohn maneuver, Shakir or sitar, thermal tactile stimulation, Masako maneuver. All of these, there's even a couple of apps that you can practice and review this and see how those exercises are helping for different phases and different specific areas of the bolus management. Okay. Then if you go into other approaches that we have neuromuscular stimulation, neuromuscular electric stimulation like AmCare, Viral Steam, and others. We have protocols like the McNeil Dysphagia Therapy Program, strategies that you use during mealtime, surgical options for some clients. So depending on what your clients need is what you need to be focusing more. For example, if we think about postures and maneuvers, chin tuck, head turn, head tilt will help with trigger the bolus or closing the diameter of the area, making the bolus to go faster, protect the areas, or clear the airway with a supraglottic, with cough. And you need to be aware also about the contraindications. So why? Because when you're doing in the praxis some of these decisions, you have to make or be aware that maybe this sounds like a great idea, but Shakir is not great for someone who have a cervical issues, or maybe where you're doing a lot of coughing and supraglottic and pulling or pushing, that could be for someone with high blood pressure or cardiac issues a problem. So people who have cognitive decline, or they cannot follow instruction correctly, this has multiple phases or stages, instructions that they have to follow, and it's not that easy for everyone to coordinate that in a safe way that the bolus doesn't go into the airway. Okay, we want to be sure that our clients are safe and that you are making decisions that are taking into consideration the whole aspect of your client. Not what because this goes well with this diagnosis or this specific issues that is happening with the bolus, I'm going to use this. You need to know more about what is the issues are happening with your client. Then remember to identify what is the primary problem. Is safety or efficiency. If it's safety, I need to make that bolus to go faster to where I need to go. And if it's efficiency, I need to be sure that there's no a lot of residue there, so I need to do a better strip of the area, increase nutrition and hydration. So start looking at how making that mealtime more functional, and that goes with quality of life and their culture and the beliefs, and respecting their autonomy of your clients, and don't overcompensate, putting everything that you have in your tool of approaches or your toolkit, and present what is the best for your client. I think that always a key element. This is, again, it's a lot. I could talk forever. We haven't even had the chance to go in depth in talk about pediatrics, but I hope that this gives you an idea of all the topics that you need to be aware. Kind of like there's kind of like a similar description of pathways for children, but of course there's a lot of areas that you should be refining or going over your class to make you feel more confident in terms of pediatrics. Always mention ITSE. ITSE, you need to be familiar with levels, like level 0 and level 7. Those are where you want to have all your clients in 7 and 0. So if you have a client that you want to be very careful, or you're going to downgrade their diet, you need to downgrade their diet from a 7 to a 5, and solids and a liquid from a 0 to a 3. That will change their quality of life from normal to really restricted or limited in terms of pleasure. So keep in mind understanding what it is, how it is applied, because you may need to make decisions related to how to modify diets for your clients to be in the safest way. What else? I think I don't have enough time, but to say thank you, and I wish you all the best. I can meet with you if you want to meet with me and have a conversation about a specific topic or a case, or as needed. Has been a pleasure. I hope that you nail that praxis in the dysphagia area with this short survey. Summary is not maybe enough, but I hope it's a good beginner, a good kick you right there into like, oh yes, I want to go back and love more about what I know about dysphagia. And has been a pleasure. My name is Maria Centeno Vasquez, and thank you for your time.